Thandeka Dlamini today on this day, 24th of July, at this time, at 9:25 at Eswatini Mbabane, conducting an oral interview, Global Oral History of PEPFAR Project. To begin with, Dr. Haumba, could you please start by introducing yourself, where you were born, your family, and where did you go to school?
Yeah, good morning, Thandeka. My name is Samson Haumba. Malwa is the family name. I was born in Uganda. I studied in Uganda most of my earlier education and postgraduate, and then I did a PhD in South Africa. So Uganda is found in Eastern Africa, and I'm born in the eastern part of the country from a district called Butaleja. I went to school in the east, my primary school and secondary school, before transitioning to the university, Makerere University in Kampala. At Makerere University, I did the Bachelor's of Medicine and Surgery. After my MBCHB, I also did a Master's in Internal Medicine. And after that, I did a Master's in Public Health. All this time, I was based at Makerere University and the Mulago National Teaching Hospital. In 2002, I joined a US-based organization that was offering HIV and TB services integration as a secondment from the Ministry of Health. The project was called the TB HIV AIDS Integrated Model District Program. I joined as a TB specialist, having been seconded by the government of the Republic of Uganda to this project for 4 years. But after the project ended, I then later joined another US-funded project in Eswatini, and that's why I'm now here in Eswatini.
Thank you so much, Doc, for that background. But you did not tell me what your PhD was about.
Thank you. My PhD was on drug-resistant tuberculosis and hearing loss. You may recall that we had a crisis, an epidemic, so to say, of drug-resistant tuberculosis in the early 2008. And as part of the response, there was massive treatment for MDR-TB. But one of the issues with the treatment at the time was hearing loss. So many of the patients who received the life-saving medicines for drug-resistant TB also ended up with hearing loss. This concerned me as a public health professional, and hence I got interested in how do we mitigate the effects of the medication to tuberculosis, multi-drug resistant tuberculosis, so that we can improve the quality of life of the patients who were getting hearing loss. In fact, one case that concerned me very much was a student, a Swati student who was studying in the University of Pretoria. She got multi-drug resistant TB, and when she was started on medication, she totally lost her hearing. And it was so difficult to communicate with her. She was stigmatized, and because that was the area I was working in, tuberculosis and HIV. I decided to pursue my PhD in this area. So basically, my PhD was on best practices for monitoring and reducing hearing loss due to multi-drug resistant TB. And as a result of this study, my study, we were able to introduce monitoring for hearing loss by basically, there are some simple equipment that you can use, audiometers, to monitor someone over time. And for people who are at risk, then change the medication that they are on. And one of the recommendations was to move away from the injectable medicine to the oral medicine. And as part of my PhD recommendations. And I'm glad that the public health policy changed. And now for multi-drug resistant TB, we are using mainly the oral medication or medicines that is safer for hearing loss.
Thank you so much, Doc, for elaborating on your background about your PhD. So now, when did you hear about PEPFAR for the first time, if you could recall?
Yeah, I heard about PEPFAR in 2003 because I was in Uganda and I was working with an American organization called JSI, John Snow Institute, that was running a USAID program in Uganda. So when PEPFAR was introduced, we were one of the first recipients of PEPFAR funding. Our project received PEPFAR funding. And I remember those days when ARVs were so difficult to get, or they were so expensive. I had a relative who unfortunately had contracted HIV, and we couldn't just afford the medication. And so when PEPFAR came in, all of a sudden there were these medications that patients could access. And my program, the AIDS TB Integrated Model District Program, was one of the pioneer programs to facilitate access to antiretroviral treatment under PEPFAR.
That is very interesting because we've been trying to track people that were involved in the initial stages of ART being available in Uganda. And we're going to talk about that a little bit. I have a question specifically. So I'm happy to note that you were in the front line of this kind of intervention right from the beginning. So could you just clarify a little bit the organization you were working for back then? I know you're saying it was around TB. So what was your role when you were working within that organization?
Okay, maybe let me backtrack a little. When I finished my degree in medicine, I started work at the National Referral Hospital in Uganda called the Mulago National Referral and Teaching Hospital. That was in 2000. It was 1996. Yeah, when I started work there, and I enrolled for my master's program in 1998. When I finished my master's program in internal medicine, I then worked in the Department of Medicine as a specialist physician. And in 2002, that's the time when I joined JSI under this project. So the project was a collaboration between USAID and the Ministry of Health. And at that time, the Ministry of Health was able to second people to this program because it was a joint venture between the Ministry of Health and USAID. So I joined in December 2002. So that's just before PEPFAR was introduced. So the organization was called John Snow Institute. JSI, but was running a program that was initially funded by both USAID and CDC. It was focusing on in the integration of HIV and TB, including PMTCT, but trying to create a model district program where these programs were integrated and managed at a district level. So the project was working in 16 districts of Uganda, actually covering both all the regions, the north, the east, the west, and central. And my role, when I joined, of course, I'd been working as a clinician, a specialist physician. But when I joined, the focus was on tuberculosis, scaling up tuberculosis treatment. At that time, WHO had introduced what they call the DOTS program, directly observed therapy short course. So that was my main role at the time, but also to integrate the tuberculosis activities with the HIV activities. However, we soon discovered that there was a challenge in the diagnosis of tuberculosis. And so another portfolio was added to me, that was the laboratory services. So at the end, I was a tuberculosis and laboratory services manager. In that role, therefore, I both increased the diagnostic capacity for tuberculosis, but also the access to treatment and adequate follow-up. One of the challenges at the time was treatment success was very low. And treatment success was low mainly because when people started medications, TB medicines has a lot of side effects. They would abandon the treatment along the way. And so this new WHO initiative of DOTS was really to try and find treatment supporters who would support a patient throughout treatment until when they complete treatment. So we are rolling out the DOTS program with the Ministry of Health. And then, as I mentioned, laboratory diagnosis was a challenge because tuberculosis diagnosis depends on sputum testing. The equipment for sputum testing were in short supply. The microscopes, the healthcare workers were not adequately trained. There were issues of quality assurance around the diagnostics. So, through the PEPFAR funding, we were able to equip, actually, we not only equipped the laboratories with equipment, but we also actually refurbished over 140 facilities, the laboratories, to scale up not only HIV, TB testing, but also now HIV testing, so that the patient can get all these services within one room.
Okay. Yeah, it looks like you're already hitting the ground running with the responsibility you are now sought out to do when you come to Eswatini.
Yes.
So let's talk about you coming into Eswatini. So what was your role initially when you came to join the university research company or council?
Yeah, research, operation.
Corporation, okay.
Yeah. So I think it is my work in Uganda that was a pedestal for my coming to Eswatini, because in the AIM program, we're able to integrate HIV and TB and laboratory services. So in Eswatini, when they were looking for someone with the expertise to assist the government, they have somehow found me. I didn't do interviews. I received a call. Then they said it was a friend of a friend of a friend who referred them to me. They asked for my CV, my credentials. We talked about it, but I was not interested at that time. I was still trying to assist Uganda, if I may call it that way. And it took about 6 months for me to accept this position. And one of the reasons I accepted, I was on this call with my to-be boss, and he mentioned that the situation in Eswatini was very bad. And that called for my inner calling to make a difference. And I could still hear those words of when she was saying the situation in Eswatini was very bad. So luckily for me at that time, the project I was working on in Uganda was also coming to an end. So I was able to request to exit the project because it was towards its end, to come and join in Eswatini. Now, URC jointly with CDC, the US Centers for Disease Control, Disease Control and Prevention, and USAID and WHO had done an assessment in Eswatini around tuberculosis and HIV, and they found that the case finding was very low, the treatment success was very low, and during that time, while the country had received funding from the Global Fund had suspended the TB grant because of non-performance. So I find myself here under URC, a PEPFAR funded program that was looking for someone to lead their efforts in the country. And the Global Fund grant for TB had been suspended for non-performance. So my roles then became support the Minister of Health, first of all, to address the priorities for tuberculosis, case finding, case holding for tuberculosis. But there is money from Global Fund that can no longer be accessed because of performance. Can you understand what are the reasons so that PEPFAR and Global Fund can collaborate to ensure that the HIV response is robust in the country. So I started work with the National Tuberculosis Program, which really didn't exist then. What used to exist then was a clinic in Manzini called the TB Center. And TB Center was responsible for diagnosing and treating TB. And the people at the TB Center used to move to all the other facilities to see patients who are suspected of tuberculosis, to diagnose them and start them on treatment. So when I came in, one of the first discussions between URC, CDC, and the Minister of Health was to create a national tuberculosis control program. And that was the first role that I was involved in, so that we could separate the clinical management of tuberculosis from the programmatic management of tuberculosis. Luckily enough, there was the Global Fund money that then was used to recruit the first coordinators for tuberculosis. The ministry appointed the first TB program manager, Mr. Temba Dlamini, to run the response. So I started working with the National TB Control Program to build their capacity, the capacity of a TB control program, including the development of the strategic documents, like the strategic plan, like the TB guidelines, and so forth. But we soon found ourselves in a huge challenge that you can't manage tuberculosis without adequate laboratory capacity. And the laboratories in Eswatini, I think we had only like 4 laboratories that had the capacity to diagnose TB. And in any case, the turnaround time for results was about 2 weeks if the results came at all. And so one of the, again, critical elements for the TB response was to work with the National Laboratory Service to ensure that there is access to testing and access to laboratory results, which would then ensure that the clinicians are able to treat TB based on bacteriological findings. So I find myself in Eswatini. Eswatini, as you know, also had the biggest per capita burden of HIV. It had the highest per capita burden of TB. And we couldn't manage HIV without managing TB, or manage TB without managing HIV. But the infrastructure for diagnosis was also very poor. And this called for the HIV program and the TB program to start working together to address the dual epidemic. In the early phases of my work, therefore, it was to bring these two programs together. Now, historically, the HIV program was better funded, both by the Global Fund and by PEPFAR. As opposed to the TB program had a grant from the Global Fund, and then through URC, there was this PEPFAR fund that were coming in, but the money was very little. In fact, at that time, the initial funding was basically to fund the position of a technical advisor, which was my position, and just a little money to do some other things. But we were able to leverage on the other resources like the Global Fund in order to have a robust TB response. Of course, over time, the funding from PEPFAR also increased to the TB program, but it was mainly through TB HIV integration. And I started my work in May 2006, and we had our first TB HIV conference that brought together the TB gurus and HIV gurus within the Ministry of Health and stakeholders in January 2007. So in January 2007, we then created what we call the TB HIV Collaborative Committee at national level, and then TB HIV Collaborative Committees at regional level. So those committees were then responsible for the dual response, as well as for the monitoring and evaluation of TB and HIV as it were. And this was facilitated by PEPFAR, because PEPFAR was very keen on amplifying the work of WHO, especially the guidelines from WHO. PEPFAR provided resources, provided human resources, provided the other resources that were required to make this work. So I worked in the TB space for 2 years initially, but I had already flagged the issue of laboratory capacity. That was very critical for any TB program to succeed. Luckily enough, through the Global Fund, they allowed us to recruit microscopists. Now, microscopists are people who can look in the microscope and see the bacteria. That's their main role. there was no position for them in the government. So we advocated that their entry level should be equivalent to the level of a phlebotomist, because they are phlebotomists in the government structure. And so they were called microscopists, phlebotomists. They were trained on both aspects. And what this did was, as a short-term measure, it increased the number of people who could work in the lab to increase diagnosis of tuberculosis. In the long run, we also started a program of, we call them scientists, who people had finished their degrees, in BSc degrees. They were looking for jobs, but they were now attached to the laboratory to be trained, on laboratory work. As we also were working on a program for introducing a bachelor's in laboratory science, which SANU is now implementing, the university, the Southern African Nazarene University, and now most recently MCO, the Eswatini Medical Christian University. So those took up the mantle to increase the production of laboratory specialists. And therefore, this whole thing that started as microscopists to produce locally grown laboratory people has now grown into formal training of laboratory technicians in the country. So in 2009, URC also received a PEPFAR funding for a 5-year laboratory project.
Was that the first time you had PEPFAR funding in 2009?
The PEPFAR funding started in 2006, 2007.
Okay.
Yeah. Eswatini was not among the first countries. It came later. I think in 2007 is when the PEPFAR coordination office. No. Sorry, I think it was 2005, 2006.
Okay.
Yes.
Because when you came, it was already there, just at
infancy.
Yes,
it was at infancy.
Okay.
Yeah, because I remember very well my first meeting with the PEPFAR coordinator when I was being introduced.
Christine?
Yes, Christine.
Stevens.
Yeah, Stevens. Yeah, Christine Stevens. Yeah. Mm-hmm.
All right, so you're talking about in 2009 when we got another funding for
PEPFAR for laboratory.
The 2005-6 one, what was the focus of that one?
The focus was TB.
Or just TB for the first one?
And TB HIV integration.
Oh, yeah.
It had 3 main aims. One was increasing the diagnosis of TB. The second was increasing treatment success. And the third was integration of TB, HIV, the management of the dual epidemic.
Okay.
Yeah.
Then now 2009, you have a second grant. What's the focus of that?
The focus is to increase HIV and TB related diagnosis and quality assurance.
Okay.
So in the second grant, basically, it was to introduce the new diagnostics, and we had the new diagnostics in HIV, we had new diagnostics in TB. That was number one. Number two was to increase the quality management systems, to introduce and scale up quality management systems so that any patient who receives a diagnosis, it is quality assured. And the number three was to increase the quantity and quality of human resources for the laboratory. And then we also started on an accreditation system where labs would then go into a process of becoming certified to offer quality laboratory services. But if I can backtrack a bit.
Sure.
In 2006,
telling me the stories. That's all I'm here for.
Yes, the initial focus was TB. But in October 2006, we got the first USAID. No, it was CDC, the first PEPFAR grant. So the first one was CDC funded, and I'm not so sure whether it was PEPFAR or not PEPFAR.
Yeah.
But it later became PEPFAR in 2008. But in 2006, we got a grant that was supposed to scale up HIV testing as URC. So this grant was to promote provider-initiated HIV testing. If you remember at the beginning of the response, it was voluntary, HTC. Yeah, but now we are doing the provider-initiated testing, and we started by introducing it mainly in the TB settings, in the inpatient setting, those settings where you were likely to find people living with HIV who are not diagnosed. And then, of course, later it became a mainstay mode of diagnosis for HIV. Then, so in 2009, we then had these 3 projects. One focusing on TB HIV, one focusing on HIV testing, and the other one focusing on the laboratory. And they sort of complemented each other very well. In 2010, our project changed with a focus on quality improvement. So it was still in the area of HIV, TB, but now focusing on helping facilities to improve the quality of the services. It's more like a health systems strengthening approach, where whatever you do, you need to find the performance gaps. Why are you not reaching the optimum performance? And then work towards changing systems, processes, and redesigning workflow in order for you to achieve the optimum performance for whatever area, and apply the quality improvement to TB, quality improvement to laboratory, quality improvement to HIV, and whatever we're doing. My journey with URC ended in 2020, but by the time that I ended my journey with URC, we had received multiple grants. Some of them were renewal grants, but the final grant that we received under URC was from the Department of Defense, where now we were supporting the Eswatini Defense Force, the Umbuto Eswatini Defense Force, to also respond to the TB and HIV epidemic. So it was the first of its kind in Eswatini for the military. But in other countries, through PEPFAR funding, they had received funding to respond to the military HIV crisis. And so in Eswatini, this started in 2018. And we supported the Minister of Defense and the Defense Forces to conduct their first sero survey. Now that sero survey was to identify the prevalence of HIV within the Defense Forces, but also the non-communicable diseases. So they integrated it so that based on the findings, they were able to develop a comprehensive strategic response to the issues of TB, HIV, and non-communicable diseases.
That's a lot of experience in Eswatini and what you have really done. And before we can cross over to Georgetown, there are some follow-up questions that I want to actually pose. Um, I want to find out, coming from Uganda and working within that space of HIV and TB as well. How did you find, like, what would you say were some of the people that were leading the response? There are some names that have come through, have come around, like
Peter Mugeni, yes.
Peter Mugeni and his team, and the Musevenis, they played quite a critical role at the beginning. I mean, could you just tell us a little bit? Did you have an opportunity to work with these people? Did they shape like your initial experience once you were in Uganda in terms of becoming an expert in these kind of issues? If you can talk about that.
Yeah, thank you. So to start with, I think the HIV response in Uganda would have not been possible without a strong government involvement from the top. The president of Uganda was very clear. I think once he learned the facts about HIV, he was very clear in his messaging. And at every opportunity, he really addressed the issue of HIV, how HIV can be prevented, but also if you get HIV, what should you do? And I think one of the first response, since in Uganda the military was hit hard, was to create the joint clinical research center, which was headed by Peter Mugeni, to do research, but also to do the response. Those people from both the political side and the clinical side, the research side, were very instrumental in the response to HIV. But there's also a lady called Noeline Kareva, if I remember well, who founded TASO. Now that one was from the civil society. So we had government, political leadership, the government, research, and clinical response, and then we had the civil society coming in for the response. Of course, for me, I will also talk to people who were like my mentors in the medical school, who were involved in the HIV response. People like Professor Katabira, Dr. Moses Kamia, Professor Harriet Mayanja, and the former principal, Dr. Professor Nelson Sewankambo. Those were really involved in the research, and for me, both as a medical student and as a young physician, I looked up to them and what they were doing and how they were averting death and improving the quality of life for people with HIV. Later on, when I was doing my public health, there were people like Professor Serwada, who was also a prolific researcher in this area. So those are like the people I look up to, having been involved very early on in the response.
I see. I'd like to ask a mundane question. Can you tell us about the history of URC? When did it start? How? What was its key mandate when it was started?
URC was founded by university professors at the University of Howard. That's what I'm told.
Howard or Harvard?
Howard.
Okay, Howard. Okay.
Howard, yeah, which is I think in DC or close to DC. So they started as university professors, but they formed this like public health arm, which later on then became independent to become a university research company. Sometimes they sold company, sometimes a corporation. And so It was based in the US for most of the time. I can't remember exactly when they started moving out to support, because they were global health sort of specialists, to support countries like in Southern America. I think they had projects in Guatemala and Asia. And so in Africa, their projects, URC projects, I think initially were in Western Africa, mainly focusing on nutrition. And then in Uganda, the HIV response, mainly in the military, but also with the Minister of Health doing quality improvement. By that time, when I was in Uganda, I didn't know much about URC until when they employed me to come to Eswatini. So for URC, it had many mandates, but these mandates were carved out of their contracts between the donor and the Minister of Health. So in Eswatini, the focus was, like I mentioned, on TB, on laboratory health system strengthening, on quality improvement. And what I did mention that in 2015, the URC mandate shifted from being the main TB technical partner to becoming the main HIV technical partner. So the project...
What does that mean? HIV technical partner?
So the PEPFAR partner. The PEPFAR grant.
Within the purview of PEPFAR.
Within the yes.
Okay.
And PEPFAR being the main funder or main partner for the Ministry of Health. If you are a PEPFAR main partner, then most likely also are the key partner to the Minister of Health. So in 2015, URC started providing technical assistance as a main clinical partner for the Minister for Lubombo region, but at the same time, also the national partner for HIV. So it was sort of like paired with the national HIV program as the key partner to support them. I think there were 4 main roles. The first one was updating guidelines, policies, and strategic plans, SOPs, and so forth, making sure that they're available and they're up to date. The second was monitoring of the HIV response through organization of meetings for the clinicians and for the providers, which we used to call the semi-annual HIV review meetings, where you then track the epidemic at the lowest level, from health facility level to the national level. The other one was capacity development for the human resource, training of the healthcare workers, including introduction of for the nurses before they graduate. So we have the in-service, the pre-service, yes. Yeah, introducing HIV, working collaboratively with the universities and nursing colleges to do the pre-training for HIV, so that we do not have to rely necessarily on the in-service, because the in-service for people who are already doing work, but you want to retool them, you want to skill them in the aspects of tuberculosis, and tuberculosis, HIV, and PMTCT.
Mm-hmm. Okay. So I had a follow-up question.
About URC. So URC, I'm speaking all about what they were doing in Eswatini. In South Africa, we had the other programs. URC was very big on voluntary medical male circumcision and TB. In Uganda, very big on health systems strengthening, and also with programs with the DOD. In West Africa, it was mainly nutrition programming, and then maternal and child health programming. They had programs in the Philippines, focusing mainly on tuberculosis, and in Cambodia, focusing on the multi-drug resistant malaria, because for Cambodia the challenge was different. It was really the drug resistance malaria and the cross-border effects of this.
So, I remember my question, the follow-up question. So you mentioned that you were a national partner for HIV and a regional partner focused for which region? Lubombo region. Mm-hmm. How were these decisions made? I'm just interested. Was it PEPFAR coming out to say, oh, we have decided? Was it an engagement process that involved? Who was also involved to making these decisions to say, oh, you're a national partner for this particular area and your region focuses this one?
Yeah. So I think this was some discussion within PEPFAR program in Eswatini to divide work between the agencies. So we had USAID that took on the Lubombo. Rather, USAID took on Hoho and Shiselweni. And CDC took on Manzini and Lubombo. So that's for the geographical coverage. Mm-hmm. When it comes to the technical areas for national support, CDC took on tuberculosis and HIV. Meanwhile, USAID took on PMTCT and the support systems. For instance, the health information management systems, the supply chain management, and then the prevention component, especially with the communities. So it was a discussion between PEPFAR Coordination Office, the US agencies, and the Ministry of Health. So for the program that was for Lubombo, clinical services for Lubombo, also became the national PEPFAR TA for HIV. The program that was, or the IP that was managing Manzini tuberculosis, also Manzini region for TB and HIV also became the national lead for tuberculosis. Mm-hmm. And then the one for Hoho became the national lead for PMTCT. So that's how the initial dispensation was in up to 2020.
Mm-hmm. So in essence, it was an internal discussion within PEPFAR to delineate the focus areas plus the geographic areas.
Yes.
And then you just got to be informed to say this is the decision that has been made.
Yes. Yeah. Okay. Of course, they would send out funding opportunities and we'll apply. So there were competitive processes every 5 years. Yeah.
Tell me more about that. Mm-hmm. So, I mean, so this would change from time to time. Yes. It would be possible that you're an HIV partner, but then somebody comes on and then
Yeah.
Tell me about that process. How was that done?
So, yes. I told you that in 2006, for instance, URC was the HIV testing partner. Mm-hmm. So 2006 to 2010, URC led the response on HIV testing. But in 2011, it changed. PEPFAR took over.
Okay.
Yeah, because competitive process, PEPFAR takes over. 2009, URC was the lead partner for laboratory. And 2014, ICAP took over.
So competitive, meaning you had done the work for the past 5 years, mm-hmm. and they feel that you are not competent enough, and then another partner...
No, it's not a feeling. You compete. So they put out a
Using what type
proposal.
of
They
measures?
they put out a proposal,
Mm-hmm.
which is called a notice of funding opportunity.
Mm-hmm. Not for
Many organizations apply.
Mm.
Tens, maybe 20s, I don't know, apply. They do an evaluation and they give it to the best applicant.
Mm.
So in Eswatini, there have been 4 main dominant organizations.
Mm-hmm.
We had URC, we had PEPFAR, we had ICAP, we had MSH. And then of course we have IHM that came in on the data side. Yeah. So they would put up 5-year funding opportunities, and we had to compete for those opportunities
Against each other. Mm.
but against many more who probably never featured. Yes.
Mm-hmm.
But there were also global mechanisms. So URC, for instance, the first funding for TB came through a global mechanism. So the global mechanism was a mechanism with USAID on quality improvement.
Mm-hmm.
So USAID, because the mechanism already existed at global level, so when the ministry wanted that mechanism to come and support TB, then they worked with URC to come and support the HIV TB integration. So that one was not competed for locally. Okay. There was already a mechanism at global level. Yes, mm-hmm. Which then the country mechanism here pulls that technical assistance, and then the agencies, the USAID, the PEPFAR agencies put in money. Mm-hmm. So a mechanism exists at global level, but if you want it, you put in money, and then that mechanism will come to support. Yes. So there have been those parallel systems that have been ongoing.
I see.
Yes, but based on the geographical and the technical areas, then it is either CDC or USAID who will put in the money to, yeah.
Got it.
So like I was saying, ICAP, since the inception of PEPFAR in Eswatini, mm-hmm. was the main HIV partner. But in 2015, it changed to URC. And while URC...
You are the ones who won that award.
Who won the award.
For
yes,
HIV,
for HIV.
Leadership in the country.
Yes. Mm-hmm. Meanwhile,
they took away
the lab from us, and they took TB also.
Okay. So were you already aware that this is how things were going to happen? In terms of like after 5 years, you have to reapply?
Yeah, we know that. Yeah, well, once we join projects, you know.
How would you say that process has been? I mean, was it a good approach? I can imagine what kind of relationship issues and tips. What can you say about that process?
It's very competitive. And sometimes some partners don't take it well. Ideally, you would want to continue being the implementing partner. And sometimes your innovation strategies are cut short because of the funding cycles. But from the donor side, they want the best. So maybe that is also the opportunity for them, if you have been underperforming, to get in somebody. But even if you've been performing well, it depends on how people write these proposals. Some people may write very good proposals, but they don't have actually the capacity to implement those proposals. So it is an approach that is used by the agencies that fund PEPFAR programs. It has its merits. It also has its demerits. Yeah.
I can imagine. I mean, if somebody... Has it happened that someone was part of the squad, if I may say, and then maybe they are told, like, I mean, UFC is no longer there, it's Georgetown now.
Yeah.
Does that mean what happened to URC? They were not competitive enough, and then Georgetown took up the portfolio, or was it something different?
Yeah, so I must say that URC is still around.
Okay.
But you remember I told you that in 2018, URC won the Department of Defense grant.
Oh, yeah. Mm-hmm.
So it's now focusing on the military.
I see.
Yes. So it is still around, but now focusing on the military. So in 2020, now Georgetown takes over from both ICAP and URC.
So now Georgetown is the big.
Yeah.
So does the URC get subsumed into Georgetown, or they're independent?
They are independent.
I see. Okay.
So ICAP is also independent, but now ICAP continues to work in the lab because they won the lab, and also research and surveillance.
Okay.
So Georgetown, who was a newcomer, takes over Manzini and Lubombo, and also takes over the national TA leadership for HIV program and for TB program.
Which is what URC at some point was a leader for, right?
Yes, so URC and ICAP.
So in essence, Georgetown toppled URC in terms of the portfolio.
Yes, yes.
I see, and you were lucky or whatever, you're also, enlisted to now head Georgetown, because it was not an automatic transition.
No, it was not. It was not. It was a totally different
So how
process.
do you come to Georgetown, if you can explain to us that? Because there's still a bit of Georgetown that was funded by PEPFAR, right? When you came on board, it was still through PEPFAR.
Yeah, no, that was from Bill and Melinda Gates.
Oh, that was Bill.
It was a small grant with the Ministry of Health. Yes.
So Georgetown is not primarily, it didn't come through PEPFAR funding.
No.
To work in Eswatini.
No.
Oh, I see. Which is what they explained why you still have operations now, because it was not mostly from PEPFAR.
But now it is mostly PEPFAR.
Okay.
So, just to, like I was saying, that in 2015, for the 5 years leading to 2020, URC was leading the response in Lubombo and also the national HIV partner. ICAP was leading the response in Manzini and also the TB national partner. In 2020, Georgetown takes over. So they took over both Lubombo and Manzini, as well as both HIV and TB national technical assistance. So when, then you asked me a question, how did I come to Georgetown? Yeah, of course, I could have remained with URC, and URC wanted me to remain because even after these programs had gone, we still had the defense. I was still the lead for the defense, which is also it's an independent project funded by PEPFAR, but it's much smaller. So I could have continued with URC, but Georgetown came with a proposal. I had decided actually to leave, just for record, and I'd gotten a position,
an offer with
in Zambia. In Zambia. Yeah. So when Georgetown comes, I consider their proposal, and for me, it came at a time of COVID. Relocating would mean different things for the family, for myself, and I thought that they had a new challenge, because Georgetown, the way, and I think that's why they won the grant, was that it was not just to provide technical assistance, as it were, and implementation support. It was sustainability. Georgetown came on a platform of sustainability and transition to the Ministry of Health. Basically, my role was come in and work yourself out of the job. So for me, this was a new challenge. And like I've told you, I've been around for all these years. I've worked with the TB, I've worked with the lab, I've worked with HIV, I've worked with supporting other health systems, including setting up the National Health and Human Research Review Board, that is for the National Ethics Board, and the research program. So for me, basically, I was almost done with what I could offer for Eswatini. So when Georgetown comes with this thing of, we want to focus on sustaining the gains and transitioning.
The gains that have been supported through PEPFAR,
Through
right?
PEPFAR.
Got it.
Yes,
Okay.
yes. Yeah. And then transition to Ministry of Health and local structures.
That's very interesting. Let's talk about that.
So very interesting and very amorphous. Because while there had been many things written about sustainability, the demonstration of sustainability wasn't there in any country, let alone in Eswatini. And so when we start, and this concept of transition to self-reliance had also been started by our principal investigator, the Honorable Professor Dr. Mark Daibo. Because Daibo at Georgetown, yes, and there was Bazira. They're the ones who are the co-directors for the Center for Global Health Practice and Impact. And it's the one that had won these two programs in Eswatini. And so when we interacted, they reached out, we interacted, and they thought that probably I was the best fit for taking these projects forward. The experience that I had in the country, but also the linkages and the networks that probably I could facilitate the issue of transition. Now, to transition to the government required a multi-sectoral sort of approach.
Maybe let me just ask a follow-up question before you can talk about what it entailed. So what was the initial goal in terms of like the milestone, the target for what would it be to show that you've transitioned, and what would be the indicators for sustainability? Because this is now how many years since 2020?
Yeah.
So this is 5 years. So I'm sure you would have like annual targets or 2 years. So what was the overall picture before we can like break it down to say that we are how far from to reach that target?
So when the NOFO was advertised, there was nothing around transition and sustainability. Georgetown put it there.
I see.
Because
what was in the original NOFO then that they responded to?
Yes, the original NOFO had 3 main objectives. The first one was to support Eswatini achieve and maintain epidemic control. So working with the Ministry of Health to ensure that there is comprehensive, quality-assured HIV/TB services. The second objective was to build the capacity of facility managers to lead the response, to plan and implement HIV/TB guidelines. The third was to use strategic information to monitor the epidemic for TB, for HIV, for cervical cancer. So integrating use of data in day-to-day planning and monitoring of the epidemic. So those were the 3 main. But the architects from Georgetown were like, for us as a Center for Global Health Practice and Impact, we want to leave a lasting impact And the lasting impact is if we can capacitate the government and the local structures to take over the response.
I see. So now coming into Georgetown, incorporating that transition and sustainability, what is it exactly that they were aiming to achieve?
Yes. So what they were aiming to achieve was that in the 5 years, or shortly after the 5 years, because transitions can take time. One is that the first 2 years of our project was to achieve epidemic control, which meant that epidemic control for every subpopulation. Because epidemic control, you can achieve it at population level, but with one population over-dominating, and the 95. But we wanted to achieve epidemic control for all subpopulations that include children, the adolescents and young people, and the adults. Then the women and adolescent girls and young women. So those subpopulations, including key populations. So for each subpopulation, so the first 2 years were to achieve that, which was achieved.
Okay.
From year 2 to year 4 was measured transition.
Which is 22 to 24.
Yes. To say that 50% of the work that Georgetown is doing is transition to the ministry.
Okay.
Then year 5, 75%. And in some areas where it is feasible, 100%. But we knew that we may not be able to transition everything within the 5 years. And so work with the ministry to develop a roadmap for transition of the remaining items.
So please break down to me, when you say transition to the Ministry of Health, does that mean staff? What does it mean in granular details to say that we have successfully, or we're at 75% rate of transitioning to the Ministry of Health?
Yeah. So we had some measures and milestones which we had anticipated.
Such as?
Yes, transition of staff.
Okay.
The transition would be broken down into the programmatic transition, the technical transition, and financial transition. Now, we did not come in with focus on the financial transition, because as Georgetown, we are not the funders. But programmatic and technical, we could do something. And so programmatic is that the ministry is taking leadership on some of the things that technical partners do. For instance, development of guidelines, planning for the mentorship, and so forth. Then the technical part is the actual delivery of services at health facilities. That the workforce is skilled and has the right attitude to deliver the services. And that's where mentorship comes in. And that's where the regional health management committees come in, the facility managers come in, and so forth. They are taking over the roles which our mentors would do. And then the human resources, instead of residing within Georgetown, then they would be transitioned to the ministry. So that was good on paper, and those were the intentions. But now, when we take on the project, we have to start operationalizing this. And so the way that the approach to this was, let's bring on in all stakeholders and understand what they understand by transition and what they understand by sustainability. And it was so amazing. We held our first workshop to just understand those terminologies. We discovered that everybody was on different space in terms of what is sustainability and what is transition. So under the leadership of the Minister of Health, the Principal Secretary of the Minister of Health, we conducted this 3-day workshop. And for the first day, it was basically everybody defining these things in their own way. By the third day, we came to sort of an agreement on what it will mean for sustainability to be part and parcel of the programming and then the transition itself. So we created working groups. One of the working groups was focusing on the technical aspects, the programming and technical. The other working group was focusing on leadership. The other working group was focusing on strategic information, monitoring and evaluation. And the fourth working group was focusing on human resources. So we brought in the line ministries that deal with these issues. So we had health and to deal with because they have the mandate for health. We had in public service because public service is the one that deals with the human resources. We had in economic planning, the one that deals with the long-term plan. So if we are going to say government takes over, Minister of Economic Planning has to be in. And then we had finance, who then deal with financing any programs. So that was the way that Georgetown looked at it, to say, while our main mandate was to work with the Ministry of Health, the HIV response, if we want sustainability and transition to happen to the government, we need to bring in the other agencies that have the mandate. So from then we held over 5 workshops, and in each workshop we're able to move closer to the understanding, to move closer to the key milestones, to move closer to the key matrices that we'll use for us to measure whether the transition has actually happened or not. And the ultimate goal was to develop a roadmap. This roadmap would then be shared with stakeholders, knowing which stakeholder takes what and what do they do. We later realized that in order to implement that roadmap, the PEPFAR funding alone is not enough, because PEPFAR funds focus on certain things. There are certain things which you need in order to build a robust, sustainable program, which PEPFAR may not fund. So we started identifying those elements. First of all, the matrix we did was, what are those elements that the government is doing that can easily be transitioned? What are those elements which the government is doing that still require substantial capacity building before they take over? And then what are those elements that the partners are doing which will need to be transitioned regardless of capacity and resources, because you're building self-reliance within the ministry to respond to their own challenges, and using any resources, their resources plus resources which may not necessarily be PEPFAR. Now, this said, you sort of asked me where we are with this. In a way, we are in year 5 now for this CSEC program. Yes, we've been able to make some transitions programmatically and technically. Some human resources who have been transitioned to the Ministry of Health. The only challenge is their transition to the Ministry of Health, but through another PEPFAR-funded grant. So,
and a different partner.
Which
is?
The MOH core, Dr. Butelezi. Yes.
Okay.
So we've been able to transition nurses and other cadres. We've been able to transition the team that we used to support at national level, the the programmers within SNAP and within TCP. We've been able to transition the leadership for planning trainings, for instance. We used to do the plans with the ministry, but now the ministry does the plans with us. So we created what we call communities of practice, where, for instance, doctors discuss the difficult clinical cases. We used to lead that, we used to fund it, but now the ministry has taken over. So the SNAP will organize those meetings for the communities of practice to discuss the difficult cases. Of course, we all come in, but it's now led by the ministry. So we are now working on the issue of mentorship, where the minister can lead the mentorship. What is the challenge has been that in our transition plan, the minister was supposed to come up with a national mentorship and support supervision framework. Now that one has delayed. And so there are no clear structures currently in the ministry to take over some of the work that we are doing. So that's work which will continue to work on. But before I finish on the transition, there was something which was an interruption, but maybe a good interruption. Because when we had started this work as Georgetown, and PEPFAR Global also took it on. I guess PEPFAR has always wanted to do this transition, but it was not like the main trajectory at the time that Georgetown took over. I know that earlier on, I think to 2010, PEPFAR tried to transition to local organizations. And I think that experiment was not very good because the local organizations then were not prepared. And so PEPFAR continued using international implementers as they built the capacity of the local implementers. So the work that we did in Eswatini, for instance, identifying these technical working groups where you will discuss the issues of transition, the issues of transition, what are the matrices, what are the milestones, somehow also was bubbling in PEPFAR. And our principal, Mark Daibo, was a former PEPFAR coordinator. And so in some of the forums where he sits, I think some of this work was being shared. And when the Honorable Ambassador Nkengasong took over, he started these listening programs where he would listen in, but they were themed almost along the same themes that we had been doing in Eswatini. So for instance, listening into global leadership, the leadership pillar, then there was the service delivery pillar, and the strategic information pillar, and so forth. So in the PEPFAR, the next PEPFAR funding cycle, I guess countries had been directed that they need to develop sustainability roadmaps.
So was that the first time that PEPFAR made that expectation clear, or it had always been a salient issue but not really followed up or monitored?
Yeah, it has always been there, but very silent.
Okay.
And not monitored, and no framework given. So this was the first time.
It was just an aspiration.
It was an aspiration.
Okay.
Yes.
Got it.
So this was the first time they were really coming in to say we need a structured way that we can do this sustainability and transition work at a national level.
So you mentioned that PEPFAR tried transitioning approaches in 2010, but it didn't.
Around it, yeah.
Yeah.
It had challenges.
Yeah, can you just talk about that briefly?
I'm not sure I'm the authority who can talk on that, but as an implementing partner,
yeah, from your perspective, yeah.
From perspective,
yeah.
So they tried to move funding from international organizations to local organizations.
Okay, so that localization agenda was one way in which they were
Yes.
trying to do, and
Yes.
the local NGOs or partners were not fully capacitated,
Were
and
not
hence
fully
they had to
capacitated.
pause
They had
to
pause.
focus
Yes.
some efforts into building
I
capacity.
know that in Uganda, one of the follow-on project was given to a local partner, but it had to be removed after about a year or two because the partner was just.
So that was one aspect, to remove international forefront leadership to local.
Yes.
What was that? Do you
The
know another pillar?
second, yes, another pillar was where agencies were given thresholds to say, in this year, we want the funding 50% to go to local partners. 70%, I think by the time Ambassador Bax left, I think it was about 60 to 70% of funding to go to local partners, those thresholds. But I think at that time, there was no systematic way or roadmap that had been developed. Yeah, and this comes under Ambassador Kengasom, and it becomes one of the pillars, the focus, sustainability and transition.
I see.
And what I can say is that while our process probably had started a little earlier, they were learning from it. But it's not the only source of learning, of course. There were other maybe places where lessons were taken from, but it was also the vision of PEPFAR to do so. So that's why I said there was an interruption, but a good one, in that our transition and sustainability agenda was now viewed as an agenda for the project and the Ministry of Health. But we had to have one national transition and sustainability roadmap. Because you can imagine that Georgetown is only supporting Lubombo and Manzini. So what happens to Hoho and Shiselweni? So this...
Or even in your approach as Georgetown, it's geographic, it's not national.
It was national, but starting with Manzini and what as a pilot.
Oh, so it was a gradual.
It was gradual. Okay. So that then, using those lessons, you could rapidly scale up.
Okay.
But in the discussions, Hoho and Shiselweni were involved in the discussions.
But just not implementing.
Not implementing.
Got it. So transition was from international NGOs to local, and then a proportion of the funding. Those were the two major pillars of the transition, as far as you know.
Yes. But there's also government-led. So there's the issue of government-led, but also government implementation. Okay. I think that was the other pillar. So, but what is coming out very clearly now, the local response is government-led response. And then the local partners and structures are part of that. Yeah.
In the PEPFAR cycle for the NOFOs, if I may call it that, where were we when the funding stopped in January? Were we 5 years there, or 3 years before the 5-year cycle finishes? Where was the time?
It really depends on the agency, USAID, CDC, Department of Defense, and it depends on the project that is being implemented. For instance, for Georgetown, we have 2 projects. I didn't mention this earlier. We have this one, and we have another one called Blossom. Blossom is a community. It's building local organizations and structures to maintain HIV response. That's a community program, but this one is a facility-based program. So for CSEC, we were in our 5th year. We are in our 5th year. So technically, it is ending in September 2025.
Okay.
But in December, CDC had put up new NOFOs.
Of 24, December of 24.
December 24. And the submission was due early February 24. Then they would evaluate, and then they would choose who else continues. Any organization was eligible. Of course, there was the eligibility criteria, with some NOFOs pivoting towards local organizations and some NOFOs pivoting towards international organizations. But that whole process was now also halted, and we don't know what will happen in the future. So CSEC was in the 5th year. Blossom, the community program, was in the 3rd year. So right now we are in the 3rd year and we are going into the 4th year, again, depending on PEPFAR funding and PEPFAR directions. EGPAF, also funded by PEPFAR through the Aspire project, was in its 3rd year. So they were also just going into the 4th year. ICAP and MOH COAG, they are on the same timeline with CSEC, so they are in the 5th year.
So I see that these are continuing, and yet there was the hold. So are you finishing up funding that was already in your coffers, or how are you able to fund the ongoing programs?
Yeah, we had funding already in our coffers. So when the stop work order came, we halted everything. And then for us, then there was the limited waiver for life saving.
Explain that to a layperson what that is, a limited waiver for life saving.
So you remember when the stop work order came, everything, all foreign assistance paused, including humanitarian and including health emergencies and HIV. So on February 1, I think the Secretary of State authorized limited waiver for humanitarian and for health, as long as they focused on life-saving. So life-saving was defined for HIV programs, TB programs, PMTCT programs, those were life-saving. But things like voluntary medical male circumcision or prevention services were not considered life-saving. So on the 12th of February, we were allowed to put in applications for life-saving to modify our implementation to life-saving, which we did, and I think all the partners did, except many of the community partners, the young heroes and what, because probably they didn't have a clear life-saving mandate. But then, I think on the 15th of February, 14th, 15th, there was an injunction, the temporary restraining order for CDC. So the temporary restraining order by the judge, therefore, mandated that for CDC partners, we go back to our pre-January 24th implementation.
So business as usual? Business
as usual.
Okay.
Because we had the funding, so we continued. So that's why we are continuing up to now.
So just only CDC, not USAID?
USAID, DOD continued under the limited waiver.
Oh, I see. Okay.
So everybody had been opened up for the limited waiver. But CDC now got this temporary restraining order that then enabled the pre-January 2025 to January 24th implementation. So we opened up, including prevention activities. Yeah.
So EGPAF, why wouldn't they, or maybe they didn't apply?
No, EGPAF continued with the life-saving. But you remember there was the foreign assistance review. The report hasn't been published yet, and I think it is in the process. I think on that fateful day, do I remember, was it 11th March? I don't remember the date. But out of about 9,000 organizations that were being funded through USAID, 6,000, I think 6,900 were terminated.
And it happened to be one of them.
And PEPFAR happened to be one of them. And because I'm formerly with URC, URC had a lot of USAID funded projects as well, including a big one in Uganda, the Uganda health activity. All these were victims of the process.
Okay.
Yeah.
That is a lot of experience within the HIV field in general, both in Uganda and Eswatini. So I'd like to glean in like some reflections from you after being involved in this process for so long. I mean, how do you feel about your involvement in this process? Because you have an experience pre-ACT, you have an experience during ACT, like from 0 to 95, and now looking into the future. And what do you feel about your involvement in this and how it has impacted you personally and professionally? And how you look at global health or public health?
Yeah. What can I say? It's been a journey.
Yeah.
And I think a pleasant journey that makes one smile because of the contributions to improving the quality of life of people, millions of people, averting death through the generous PEPFAR funding and building structure. So when I reflect on myself, certainly I was, my line at the time before I joined the programs was clinical medicine. In fact, my doctoral study then, which I had started working on for my PhD in clinical medicine, was not necessarily related to HIV. It was related to diabetes and renal disease. But when I now joined the global health PEPFAR, it now changed because I looked at what were the issues at the moment and how I would contribute. So academically, PEPFAR has enabled me to contribute to new ways of doing things, new ways of treatment, including the abolition of injectable medication for MDR-TB. So that's from a personal level. But coming to programmatically, I've been able, I've learned a lot through the process, but I've also given back quite a lot through what I've learned. My main interests have been tuberculosis, HIV, laboratory medicine, and health system strengthening, and then research and research development. I've been able to contribute to those areas in a substantial way, both in Uganda and in Eswatini. I can comfortably say that the TB program as is now, it is formation and it is largely due to the efforts through PEPFAR. Of course, I was at the forefront with my organizations at URC at the time where we really built the TB program to what it is. We've also, just beyond TB and HIV, like I mentioned, we've contributed to the establishment of the National Research and Innovations Department, which did not exist prior to URC being here. But because URC was also very interested in the development of evidence I again worked closely with the Ministry of Health, and they appointed people, officers, to run this department. And I think it was again that catalyst that then eventually made CDC to start a grant that was really to support research and surveillance in the country. Of course, ICAP has been the implementing partner for that one since it started, I think, in 2010. I've also been involved in the National and Human National Health and Human Research Review Board from the time when initially in Eswatini, I think there was no committee really. The Director of Health Services would review and approve research grants. And then working with WHO, URC and WHO work with the ministry to create the SEC then. And then the SEC now graduated into a board. And I've been a member of that board for some time now.
SEC being Swaziland Ethics Committee, right?
Yeah, Swaziland Ethics Committee. Mm-hmm. Yeah. So now we had to develop the documents, strategic documents, guidelines, including the online portal. Actually, it was URC that paid the initial fees for the current online platform. And this was not money from PEPFAR. It was because we were interested in evidence. We convinced our headquarters to just put in money and get that online platform, which is called Rhino. Of course, when now there was a formal NOFO for research, all those then were transitioned and supported by a substantive partner, PEPFAR-funded partner. I've been involved in the strengthening of the health systems just beyond HIV, to also looking at the strategic information, the data systems, and so forth, where I've been a member of the technical working group or a think tank. And right now, we are working on Eswatini CDC, which is the National Public Health Institute for Eswatini. But His Majesty prefers that is called Eswatini CDC. But this is really for global health security, to ensure that epidemics like COVID can be predicted and detected early, so that the impact on the human beings and animals and what is mitigated. Under the Eswatini CDC, Eswatini has decided to approach it with the One Health approach. So you have health and human health, you have animal health, and you have environment. So all these are working together to form the Eswatini National Public Health Institute that will assure the safety of the mass. It is still in its initial phases, but Georgetown is also playing a big role, because at our headquarters there is a unit, the O'Neill Institute, that is involved in providing technical support to countries that are setting up national public health institutes. And the Georgetown will be supporting the Eswatini to do the legal mapping through the O'Neill Institute, but I'm a member of the think tank. So for me, when I reflect back, because of PEPFAR, it has put me in positions where I've been able to use my knowledge, use my experience to influence positively on public health, on global health, and now the issues of self-reliance, sustainability and self-reliance, as well as global health security.
Mm, quite impressive. So, can you talk about how you have seen? I know you have been very active and leading some interventions around data being available and also data being used to inform programming, used as evidence as well as research. So, I mean, how was PEPFAR making sure that there was data? If you can talk about some interventions that PEPFAR had to put in place to make sure that there was accountability for resources as well as data being used to inform programming.
Thank you. So PEPFAR, initially and mainly through USAID, was able to find implementing partners with the skill set that can help the Ministry of Health to set up a health management information system. And the client management information system is largely PEPFAR funded, or at least the technical assistance, but also with the global fund that funded like the hardwares and so forth, and of course in collaboration with the government. Yeah. So that was the first intervention of PEPFAR to make sure that the data is there and it is of quality. And for Eswatini, it is client level. So if you want to do analysis and do synthesis of what the data is telling you, there is a source. So that was the first. The second, making sure that data is available and used is through the routine programmatic reports and also supporting the government's monitoring and evaluation unit to be able to produce reports on a regular basis annually. So we have reports for HIV, for TB, for reproductive health, and so forth. So those data are coming from the programmatic implementation. So the planners are able to have up-to-date data to use for the decision making. And then PEPFAR has also funded a number of studies now, surveillance studies that have been able to tell us where the epidemic is. For instance, I think Eswatini has done 3 FEARs, mainly through ICAP, funding through ICAP. And so those FEARs have been able to tell the country where are we in terms of the 95, 95, 95, and what is the gap, what is the incidence, how do we reduce the incidence. So those incidence measurement surveys are largely PEPFAR funded and have availed evidence for programming. But also through again PEPFAR support, funding the research, National Research and Innovation Department, as well as the Ethics Review Board, you've strengthened the conduct of research, the ethical conduct of research. And so whichever data or evidence becomes available, you know that has gone through a rigorous process of peer review, and the human subjects have been protected. Now, through our various programs as implementing partners, there are forums where we make this data available. I talked about the semi-annual HIV review meetings. They are no longer happening, but as frequent as they used to be. So we have quarterly meetings and then semi-annual meetings. The RESAs and NESA, yeah. Most recently, they've been sort of modified so that we can have both a virtual attendance as well as physical attendance. So through those efforts, relevant data and information is available for decision making, and then you can be able to track impact and progress.
Thank you so very much. So I think we've spoken about local ownership and transitioning. I will pause that. I just have this overarching question about global aid and imbalances between the West or the donor and the host country. So, what would you say has been your observation in terms of the Swazi government being able to put their foot down and to be able to guide the response vis-a-vis what the donor wants in terms and condition? You've been here for 16 years. What has been the progression in terms of, are they very strong to say this won't work, this will work, and they can go to the table to negotiate and carve out a way that would be much more appropriate for the response in the country?
I think it has been a progressive effort. The first was when the donor would do an assessment and points out that there's a problem here. And then the ministry appreciates, the government appreciates that yes, there's a problem. For instance, when this initial assessment by WHO and CDC was done on TB, the TB case finding was just 24%. At that time, WHO had a benchmark of 70%. The treatment success was just 30%. WHO had put a benchmark of 85%. So through that assessment, then you realize, oh, there is a problem. And then the donor is saying, okay, there is a problem, but this is how we want to help you. And probably the negotiations then are not like equal, because then the donor will sort of direct how the response is done. But over time, through the capacity building, the government now is aware or can be proactive in identifying what are the gaps and how does the donor cover our gaps, not their gaps. And so it is starting to change where the response and the direction is driven by the ministry. Then over years also, there have been this, what they call the COP planning, the country operational plan, where increasingly PEPFAR has engaged the local stakeholders and the government. So PEPFAR says, okay, this is our funding level to have 70 million. These are our focus areas. And then jointly the ministry and the stakeholders will sit and say, what are the priority interventions that we should do? What are the gaps? And so through that process, somehow then the donor would have to modify some of the intervention to suit the government.
From the stakeholders.
Yes. But you know, when you're not funding your response fully, you are always vulnerable. That at the end of the day, while there is input, sometimes it could be just like you are at the high table to just rubber stamp, if I may call it that way. But I think for Eswatini, progressively, because of the data that has come from the fears, the data that has come from program implementation, the ministry or the government has become aware of their gaps. And when they are sitting on the table, I have been in some forums where they insist, our issue is the death among the TB clients not decreasing. So whatever intervention we do, we need to accommodate this population. Or our young girls are 4 times at risk of HIV. So whatever we do, we just need to make sure that we're also putting in some interventions for them. So their voice has increasingly been amplified and responsive to the donor. But in terms of the imbalances are always there. The donor dictates, and sometimes for the right reason, because these are their funds, and they have to account back to their governments or back to their people. But I guess the stage where PEPFAR was going or is going is government-led. And so if we say government-led, then the government is invited to lead. But sometimes even when the government is invited to lead, it may not lead adequately because of sometimes capacity issues. And so the donor sometimes then helps them to lead their own response. I'm not sure whether that responds to your, or there are some nuances that you may have wanted me to.
It does. There is a nuance and a tangent I want to follow based on what you're saying. So, based on observation, then it's purely like subjective again. So, would you say in the tenure of your involvement with PEPFAR and HIV in the country, there are things that could have been done differently by PEPFAR in terms of approach, in terms of programming or what have you, in the larger scheme of things, as well as other things that you've observed that, looking back, perhaps if the government would have done that differently or negotiated that differently, would have reached a different, destination?
Yeah, for sure. There are many examples that I can quote on the two scenarios. The first thing really, and sometimes I would think that maybe my job is gone because of my approach to some things, was, I started working with PEPFAR programming in Uganda. And as a Ugandan, I really wanted to make sure that the donor aid, as much of it remains in Uganda or benefits Ugandans and Ugandan institutions. So in planning, for instance, if we are extending services for testing, instead of us putting a tent, the suggestion would be, no, let's build. Because when you build, you leave infrastructure there. In my approach as a team lead for my projects, but also as a PEPFAR implementing partner, on the table, we would always look at how do we respect the government, how do we get their inputs, so that whatever we design, it is designed with them and with their leadership. And certainly, sometimes it's an uncomfortable discussion, especially if you're just looking at the money. The other thing which, for instance, Eswatini did, after an experience with the Global Fund, because the initial ARVs were bought through Global Fund, and then of course PEPFAR, there was a time when the government did not have a good accounting system for ARVs, and the Global Fund stopped the funding for ARVs until when a system was put in place. But what this did, it woke up the government that, yes, we need an accounting system, but because of that interruption, I think government took a position that they are going to be buying their ARVs. Many times the donor said, can we buy for ARVs? The government said, no, we shall buy the ARVs because these are for our people. And I think that was a very strong stance by the government. It's only in the latter years when the number of people living with HIV expanded so much, and then we are having regimens that are specific for children or that are specific for people who are resistant to the first line. So then the government was able to say, okay, yeah, we are struggling here. So can PEPFAR help us buy pediatric And can PEPFAR help us buy the second line and third line medicine? But as for the first line, we are going to be buying. So what that brings is some bit of balancing of power, if I would say so. Yes, your funds are very important to support us, but we don't want to be held at ransom because of the funding, if I would say that.
You want to retain some bit of control to decide what's
to
best.
decide. So, and I think PEPFAR, of course, PEPFAR and the donors, sometimes they would want to fill a gap. That is obvious. The gap is there. But the government is not seeing that gap. So, for instance, for the pediatric doses and the third line, and there was a gap. And the government had only programmed for first line. And so the two then agree that, okay, yes, there is a gap. Can you fill that gap? And PEPFAR fills the gap. The other situation was, I think because of Eswatini having a small economies of scale, there's time when there were like a bit of shortages on the global scene. And the government needed to have a buffer so that even if stocks run low, there is a buffer. PEPFAR came in, PEPFAR came in $5 million to buy a buffer. So again, it was sort of like a negotiation. But for me, I want to say that I think over time, PEPFAR has learned, and especially under Ambassador Kengason, the issue of listening to the African governments or to the stakeholders. In that way, then the response is directed to the needs and the gaps as identified by the government. So I've talked about what PEPFAR would have done better, and I think PEPFAR has improved over time. There's these traumatic experiences under Ambassador Bax, where governments were, in a way, belittled. But sometimes I try to understand where PEPFAR programming was coming from, in that many governments had refused to take leadership. And many governments had refused to invest. So the approach from PEPFAR and Ambassador Bax was to say, you either meet the benchmark or we don't fund you. So many governments woke up. The second thing was many governments were not following the data. They didn't even appreciate what the data is saying. What are the gaps in the epidemic? And Ambassador Bax was very clear. There are a gap here, using data. And we want you to be responsive. And we want the partnership in doing this. Now, where governments were reluctant, funding was cut. And because some of the African governments had relied so much on the PEPFAR funding, then they felt the pinch. When the funding is cut, then you feel the pinch. So you wake up and start working towards those matrices that were genuinely important, although the approach was sort of different. So under Ambassador Kengason, he was sort of like listening, and let's build this partnership so that we can address the epidemic in a respectful approach. But then that also came with the growing sense of the urgency for transition, because the PEPFAR funding wouldn't be here forever. Over 20 years had governments learned lessons, and were they taking a bigger responsibility? Some governments probably were still asleep. Ambassador Bax woke them up. Ambassador Kengason continued on that, but now they wanted to build a pact, discuss how you will be absorbing what PEPFAR has been doing. So governments, what could have governments done better? I think if governments started with the use of data from the very beginning to point out their needs, maybe it would have been different. If governments had taken the interest and not reduced the health budget, because many governments, once the PEPFAR funding became available or global funding became available, they reduced the budget on health or on HIV. And so when PEPFAR funds, like most recently, are cut back, then there's a huge gap, because there has not been that incremental investment in HIV. So governments needed to have continued to invest even in the presence of this external funding that was available. So at the moment, you will find that even in Eswatini, when the question is asked, PEPFAR has been supporting a lot of lay cadres. What will happen if the funding is stopped? There's no clear answer. Government says we shall not absorb them. Then what will happen to the services? Yeah. Even when government says, "Oh, we'll take over," there is no clear demonstration that there's a budget that is being set aside, or that will be used for this. So on the PEPFAR side, it is engagement and listening. On the government side is accepting the aid, but do not reduce your own funding to the response, and should have continued to be incremental, but also building your own capacity as a government and the capacity of the local structures.
As I bring that to a close, I know that there's other entities like the UN and WHO that have to make sure that as a country where we're signatory to certain declarations, I'm not sure now where it is. I know there used to be 3x5s and the Abuja declarations and all of that. Were those things still monitored when PEPFAR came to the scene, or it was mostly now what PEPFAR was doing on the table and that agenda was lacking behind? What was happening with that? Because I assume that should have been simultaneously being monitored with the ongoing response.
No, thank you for the question. I think when PEPFAR came in, it was an ambitious program. They wanted immediate impact to avert death and to avert infections. And so there are certain things that were done the PEPFAR way through both local and international organizations. But I think very soon after PEPFAR started, they started aligning the interventions with the global guidance from WHO and from UNAIDS. And towards the current scenario where we are, actually, it has been PEPFAR who has been driving many of those WHO and UNAIDS initiatives. So once WHO has come up with a guideline based on evidence, PEPFAR partners and PEPFAR implementers then will take it up to scale. And actually what has happened is that the global guidance has been brought to scale much faster than if PEPFAR was not there. So PEPFAR aligned itself totally with WHO, and with UNAIDS, and actually PEPFAR just scaled up the implementation. So I must say that there has been no disconnect, at least of recent. In the beginning, yes, because this was an emergency, things had to happen. But PEPFAR has also helped the multilateral organizations to quickly generate evidence that they use for policy and guidelines. Because through the various PEPFAR platforms, there's been a lot of research. They've generated a lot of evidence. So now when WHO sits to develop guidelines, there is just a plethora of evidence. And so it is easier for them to come up with guidelines because there's a lot of evidence and they're using those studies to generate guidelines. And yeah, so for me, it has been a very symbiotic sort of relationship. But of course, we also know that PEPFAR in some ways has also been funding some of these global agencies in one way or another to fast track certain components of the response within those agencies. As for Eswatini, they always maintain they don't implement things except if they are WHO approved or certified. And so even when PEPFAR is bringing in something, that would be like you're piloting or it's an innovation which you first implement in a small scale. But once the WHO guidelines say yes, then you can easily scale up.
I see. Very last question, very close. There's been immense impact and influence of PEPFAR in terms of the global health direction. So, I mean, what do you think has been the most important contribution of PEPFAR, not just Eswatini, like to shape how we see global health in general?
Yeah, I think for me, the biggest impact was averting death from HIV and TB. We know that eventually, and I'm not very sure when started first with the Global Fund or PEPFAR, eventually these two were working together to contribute to global health. But for me, I think the availability of ARVs, I think for me is the greatest contribution of PEPFAR. And the systematic way of identifying people living with HIV, and then narrowing the gap between when you are tested and when you are put on ARVs.
System treat.
Yes, because then that also improves the quality of life. And these days, in fact, we've had a challenge, especially among young people, with what they call pre-exposure prophylaxis, which is a WHO recommended approach. But PEPFAR sort of puts in resources. And young people are saying, why should I take a pill to prevent a pill? Because we are saying, well, if you get HIV, then you'll be put on ARVs. But they never saw the true picture of AIDS. Because the people who now get HIV, you get HIV, you're tested, you're still looking good, you start ARVs, you continue your normal life.
It's like taking a pill for hypertension or sugar diabetes.
Yes. So we've reached that stage. So then the young people become a little more careless. Say, well, if I get HIV, I'll take the pill. And I will be no. Why should I be taking a pill to prevent taking a pill? Yeah, but above all, this whole consciousness around epidemic control, around global health security. You might remember that during COVID, PEPFAR resources were diverted to respond to COVID. And I guess, again, while it was not a formal response from PEPFAR, for COVID, the structures that PEPFAR had built helped countries to respond much faster. Above all, I think it is more of the science, promoting the science on managing these conditions, acceleration, innovation of new tools, new diagnostics, new medications that are safer, rollout of safer medications. When PEPFAR started in 2003, the medications would make people have side effects, a lot of side effects, including bodily shape, people with the harm and so forth. Yeah, but now the medication is safer, and PEPFAR was able to help roll out the safer medications.
Yeah, thank you so much for your time, Dr. Haumba. And I don't know if there is anything that you still want to add outside of the questions that I've posed for you that you want to put for record as far as PEPFAR is concerned.
I think we've covered it all, but just maybe in my introduction, I didn't mention that I'm also an assistant professor of medicine at Georgetown University. So while I do work here as a country resident director for Georgetown programs, I also have a faculty role at Georgetown. But probably this would have not been possible without PEPFAR, because it is through PEPFAR that I made connections with Georgetown.
So in that role, I mean, are you able to lecture? Do you have, are you a visiting adjunct professor? Do you offer any lectures? Because I think it's important, this kind of experience from the field of implementation, getting back, to public health specialists, medical professionals that are being on training. How are you using that role as assistant professor?
Yeah. So I have students who are doing global health, who rotate through here, but I also mentor students. Every year I have a number of students whom I'm working with on global health programs, and we conduct research, we conduct work in Swatini to use it as a platform. But whenever there is a chance, I'm able to give lectures at the university. But for now, the focus is more on the field work. We are still, I'm still working on other ways that I could use my experience to impact the academia. But for now, it's through those students who rotate through here, whom I mentor. Even when they are back at Georgetown, we continue having the academic program going.
Thank you so much for what you have done for the Kingdom of Eswatini, for Maswati, and the fact that it was a mutual relationship, because it seems you've grown personally and professionally through your connection with PEPFAR. Thank you so much for your time. We appreciate you for what you have done.
Thank you very much.